Hello, welcome to APHA's Addressing the COVID-19 Crisis, an open forum webinar series for pharmacy. My name is Sandra Leal, and I'm Executive Vice President at Symphony RX ATRHC Solution. I am also President of the American Pharmacists Association, I will be the host and moderator for today's CE session. Today's webinar discussion, we will discuss the long-term effects of COVID-19 and the advantages of the COVID-19 vaccination. We are conducting this CE program today in collaboration with the Society of Infectious Disease Pharmacists. So it's a real pleasure to have them on today, and we have some great speakers that are joining us for this broadcast. We have Dr. Christopher Bland. He is a clinical associate professor at the University of Georgia College of Pharmacy in Southeast Georgia campus in Savannah, Georgia. Dr. Bland's primary practice is in antimicrobial stewardship at St. Joseph's Candler's Health System in Savannah. He is a co-founder of the Southeastern Research Group Endeavor, Surge 45, which is a practice-based research network primarily in the Southeastern US with over 40 institutions and an 80-member affiliation. Dr. Bland has given over 100 invited regional, national, and international, and published over 100 abstracts, book chapters, and peer-reviewed presentations in the area of infectious disease. Today, we also have with us Dr. Steve Foster. He is an APHA's liaison to the ACIP, and he is a retired as captain in the U.S. Public Health Service. Dr. Foster is a strong advocate for the pharmacist's role in public health and has served as the APHA's liaison representative on the Centers for Disease Control and Prevention Advisory Committee on Immunization, ACIP, since 2001. Dr. Foster retired as a professor from the University of Tennessee College of Pharmacy in 2016 and previously served Tennessee as a chair of a committee on cervical cancer prevention and support. And he supported the development and implementation of its pandemic preparedness plan. So we have some amazing speakers. I also wanted to introduce our subject matter in-house experts. We have Mitch Rothholtz. He is our Chief of Governance and State Affiliates for the American Pharmacists Association. He is also the Executive Director of the American Pharmacists Association Foundation, and he is everything immunization for APHA, very, very incredible with his immunization background. We also have with us today a couple of other individuals. We have Dr. Dan Slott. He is the Senior Vice President of Education and Business Development for the American Pharmacists Association, and he brings 10 years of experience at NIH as an oncology infectious disease specialist. We also have with us today Elisa Bernstein. She is Senior Vice President for Pharmacy Practice and Government Affairs for the American Pharmacists Association, and she brings over 30 years of experience with the FDA. So it's a pleasure to have all of you here today to join us in this really important discussion. So let's proceed to the next slide, please. We have a few disclosures we wanted to make sure you take a few minutes to read. We'll have them listed there for the individuals participating today. And we have these learning objectives. So let's review these for CE. The first objective today is to discuss the COVID-19 disease and what is known about the systemic impact of the infection. The second objective is to describe common symptoms that result from the long-term effect of COVID-19. The third objective is to compare the impact of COVID-19 disease against known adverse effects of the COVID-19 vaccination. And then the fourth objective is to articulate the advantages of COVID-19 vaccination in the context of the long-term effects of COVID-19 disease. So hopefully you can find these informational very, very useful for the day-to-day practices you have. Here are a few questions to keep in mind as we're reviewing the information, and we'll do some pre-assessment polling. The first question is listed here. A number of long-term side effects of COVID-19 are current in many body systems due to the virus initially entering which receptor? So if you can take a moment to please select one of the following answers, and we will do the poll. We will not show the answer. We will hold that till the end and see how you learned during this CE programming. All right, thank you for that. The second question is, thrombosis with thrombocytopenia was the cause of the temporary pause in the use of which one of the following COVID-19 vaccines used in the United States? And so you have the selections there. If you could take a moment to respond to that, please. All right, great. And the last question is, considering the dozens of vaccines developed over the last 100 years, vaccine-related side effects are almost always detected within how much time after the vaccination? Great. Well, thank you for responding to those questions. So let's quickly review the format of the webinar today. So we've done the introduction, and we will have a discussion with our participants, Dr. Chris Bland and Dr. Stephen Foster. We will do that for about 20 minutes, and then we will welcome your questions in the open forum discussion. So please share your thoughts and your questions on the sidebar so that we can respond to those as we're going through. At about 1:50, we'll stop and we'll review what's going on with APhA. There's a lot of really exciting activity, and we'll be discussing what's going on and what's coming up. So we'll do that. Thank you. So with that, here are the open forum ground rules. You will find the handout at the sidebar of your chat. Please use the question fields in the GoToWebinar toolbar to submit any questions or comments that you have. We'll try to get to as much of those comments and questions as possible. So please refer to that handout. We also will have the recording 24 hours after the session is over. And CE is going to be available during the live webinar session with the code at the very end of this exercise. So let's invite Dr. Chris Bland and Dr. Stephen Foster to turn on their cameras, and we can start our discussion. Thank you so much, Steve and Chris, for being on with us today. And so let's go ahead and start with the question. This is a really, really important topic that a lot of individuals are having questions about, especially if they've experienced long COVID. So let's go ahead, Chris, and start by asking, can you tell us a little bit about your practice and what your focus has been during the COVID-19 pandemic?
Thanks, Sandra. It's great to have the opportunity to be a part of this webinar in collaboration with SIDP and APhA. It's really twofold. My job as a clinical faculty member at the University of Georgia is really an educational role as well as a practice role. So in a practice standpoint, I practice within a 300-bed community hospital and in Savannah, Georgia, where we've really just seen a lot of consistent COVID cases. A number of these, just as you know, a lot of variability as far as mild, but these are all admitted patients, a lot of intensive care unit patients. So, you know, working to care for patients, answer a lot of questions. As you know, the data comes out really on an hour-by-hour basis. So along with caring with those patients, the educational role, so working for the university, doing podcasts, doing interviews with news services, just trying to get the word out and separating fact from fiction, which I bet a lot of people on this webinar have really been doing the same thing, you know, just trying to really give patients and physicians and all those that are caring for this disease factual, timely information.
No, absolutely. I agree with you. Lots of questions coming in, and a lot of questions. And to your point, lots of changing information. So we're trying to do our best job to keep people up to date and to keep them informed. So thank you for all the work that you've been doing. And Steve, you have been a regular on this webinar, but can you please remind the audience about the work that you've been doing with COVID-19? And I know you've been very, very busy.
We've all been living the COVID dream, I'll tell you. It's and if anybody says you're not busy by staying at home, they're wrong on this. Locally, I've been doing some volunteering with the local health department and the hospitals, but most of my time spent in front of a computer. State-wise, I'm on a state committee for COVID. On national, obviously, I'm on the ACIP. And by the way, I want to point out a couple other things about ACIP. First of all, we have some people behind the scenes that are from APhA that are working very hard. Michael Hogue has been the representative for the work group for the COVID, and they have been meeting almost weekly since COVID started. Carl Hess is representative on the rabies committee. Adam Welch is on the zoster committee. So we do have some other people that are working hard with ACIP. Mitch is in constant contact. Mitch Rothholz is in constant contact with CDC. So a lot of behind the scenes going on. We've had 14 or 15 emergency meetings of ACIP since this has started. So what typically was a 3 times a year meeting has been almost a every other week type of, at least once a month type of meeting. So it's been pretty busy. The other thing that I'm involved in, obviously, is this type of stuff with information distribution and then some consulting with some advisory committees. So it's been a busy time.
Well, that was very striking to me when you said that the number of meetings that you've had, 14. So thank you so much for all the work that you've been doing on behalf of the world, really, to try to address this COVID pandemic, and then all the information that you've been sharing during the webinar participation. And thank you to all the other group of individuals at APhA, the staff. And I know Michael Hogue was part of the webinar series and trying to, keep us informed, being president and then attending so many different meetings. So that lots of work going on. But let's go ahead and start a little bit of a discussion around the manifestations of COVID-19 and the multi-system organ involvement. That's been one of the incredible things that we're learning more about and finding more about. And Chris, can you provide an overview of what you know about the long-term effects of COVID-19? What systems are impacted, what's affected by COVID-19?
Yeah, so the quick answer is not a lot. We know some things, but because we're so early in the pandemic, there's a lot that we have yet to learn. We know that because of this virus and the way it enters cells, specifically through the ACE2 receptor. So this virus enters these cells that really are everywhere. And if you look here on this slide here, you see all the different organ systems that potentially can be affected. So what I would say is what we know is very little considering on what we're going to know 3 months, 6 months, a year from now, 4 years from now. In fact, the NIH back in February announced that they are earmarking $1.15 billion with a B to research really the long-term effects of COVID-19 on patient populations, trying to answer a lot of the questions we want to know as far as who's at highest risk, what do these manifestations look like, and just long-term effects on how long these symptoms last, because we're still somewhat early into this process. And I've seen a trend in research where we were, trying to figure out how to treat this. And now we've got vaccinations, and Steve's going to talk a lot about that. And then now it's, okay, now the disease is here for people who've had it. What does that look like long term? And we know with a number of different viral illnesses, they can have long-term manifestations. So it's going to take some time, but I'm happy to know that we are committed to figuring out long-term what this does in an individual patient to give them a healthy expectation.
Great. No, and can you talk a little bit about what body systems are being affected by COVID-19? Because everything you're talking about absolutely resonates, and we're trying to learn. And every day I feel like I'm seeing something published, and I'm like, oh my gosh, this is incredible and interesting. So can you talk a little bit about body systems that are being impacted?
Yeah, I tell you, when I started researching this several weeks ago, I had to prepare for another talk I did. I quite honestly, I was overwhelmed with a lot of the data that was already present. When you look at the different organ systems involved, I've got a list there, and it looks like a packed slide, but I couldn't even fit everything on there. For example, like pulmonary, which is one I didn't get on there. But as you can see, anything from dermatologic skin manifestations all the way to some really serious long-term effects, and thromboembolism and clotting is one that really has been in the forefront, knowing that a lot of patients end up with a blood clot sometime after this disease, and it can be several months later. And I think a lot of that comes into play too with some of the more common side effects. The common ones that seem to be in the literature most of all, sometimes as high as 30 and 40% for months after, are things like fatigue, just unexplained tiredness, not being able to do their quality of life and daily activities, and they just feel like they're tired for months and months. Shortness of breath goes right along with that. A lot of these patients, as we know, have other comorbid conditions, which this disease obviously can worsen. And then, specifically the neurologic side effects, these are the ones that probably I have heard about the most. Headaches, just kind of constant headaches. At a presentation I did 2 weeks ago, an attendee stated that their daughter, who was 14 years old, had constant headaches for somewhere around 4 months, nearly on a daily basis. So I think too many times we've kind of focused on the mortality of the disease, and we should, because it obviously has significant mortality. But long term, with vaccinations and hopefully getting most of those accomplished, the morbidity of this disease and a number of different disease states or a number of different body systems is going to be something we're going to have to figure out and live with. A personal story, my daughter, another one that happens is loss of smell and taste. And my daughter had COVID back in December. And for the first time about 2 weeks ago, she came down the stairs and she said, "Mom, are you making chocolate chip muffins?" And she was so excited. She couldn't see the kitchen, but that told us that she had actually regained some of her smell back. So I do get concerned. It sounds like a mild side effect, but does that affect eating habits, appetite, and things like that, especially in our pediatric population? So a number of these adverse effects we're starting to figure out, headache, anxiety, depression, neurologic has been really taking a toll among all these different health systems for sure on a frequency basis.
Yeah, that's incredible. That's a great story about your daughter. I'm glad she can smell the muffins. It's
That's right.
so important. It's really
Yep,
key.
exactly.
Have you sensed what kinds of groups of people are getting these long-term effects more so than others? Anything like that you're finding, any trends or information related to that?
Yeah, the NIH, that's a big area that they're going to study, is really getting, evaluating all populations of patients, trying to get a good representation of a diversity of patients within these trials to be able to figure this out, because there's a lot of underreporting that takes place. One thing that's consistent that I can find in the literature is that the more severe your presentation of disease, that tends to be a higher risk patient for developing some longer term symptoms, such as shortness of breath or fatigue or some of these other neurologic manifestations. There was a recent study in Lancet Neurology that really showed this, looking at database in the United States, where a number of different neurologic illnesses were persisting for months and months after the disease had ceased, the acute illness. And what was interesting is nearly 12% of these neurologic illnesses were new diagnoses. So it's not just a worsening necessarily of something that's pre-existing, although that definitely can happen. Sometimes these are new diagnoses, and these are well done match studies that seem to go towards some causality with these illnesses. So the sicker you are on presentation, that seems to predict more of a longer term effects of some of these, but not always. The other reassuring thing is from looking at children versus adults. Children, especially younger children, say 10 and less, tend to not carry these longer term symptoms as much as adults do. But so that's somewhat definitely reassuring. But as I said, I had that person speak to me at the meeting that was 14 and who was having to get more care for her headaches. And so it's not that's why the vaccination is so important, is that it's not a zero risk, but the adults seem to be at increased risk, and especially those adults that have more severe presentations of their COVID-19.
Great. Well, that's a lot of really good information. And are you seeing any treatment options that are available to help these patients that are showing some long-term COVID symptoms?
That there's not really like a magic bullet. There's not something out there that, hey, you've got long-term headaches from COVID. You've got this new manifestation, whether it's heart failure or a gastrointestinal illness. Really, I think it comes down to screening more, as opposed to focusing on newer treatments, which we don't have any new specific treatment, but it's really screening these patients more for these illnesses. So there's not a new treatment necessarily. What I would say is it's more refractory treatment. So a lot of, especially the headache patients, where they normally can get away with an NSAID or maybe acetaminophen, they're getting new migraines. So those medications that used to work for their tension headaches, they're getting a different type of headache, and they may need different treatment.
Great. That was going to lead into the next question I had around any tips for pharmacists on how they should be considering managing a person's previous medications or medications that they're taking as it relates to some of these COVID long-term effects.
Yeah, Sandra, the first interview I did was kind of I called it fact or fiction. And it was at the time where ACE inhibitors and angiotensin receptor blockers were considered bad, like don't take these. And so what I would say one of the main things that pharmacists can do is reassure patients that if they're on these medications prior to their COVID illness, they really need to maintain those therapies, because coming off of those therapies due to, inappropriate or incorrect data that's out in the press can actually worsen that disease state and cause more harm than good. And then the other thing is, one of the findings is pulmonary fibrosis. That is something that has happened. So if somebody's persistently short of breath, then I would have that pharmacist really encourage that person to keep their appointments with their physicians that manage them, so that they can detect some of these things.
No, those are great recommendations. I know pharmacists have been tremendous in trying to advocate and triage and make sure people are still connected to care, especially when so many offices were closed in the beginning. And so now, definitely continue that very, very important critical relationship. Well, let's jump over to you, Stephen. If you can share with us what data can you share about the side effects of COVID-19 vaccine and the available safety data? And I know you were just, yesterday attending the ACIP meeting, so anything you could share related to that would be great.
Wonderful. By the way, I want to add one more thing to Chris's list of things, is other vaccines. We are really behind in other vaccines, particularly adolescent vaccines and adult vaccines. So as a screening tool, really have pharmacists jump in and screen patients for their missing vaccines. I want to say that these vaccines are safe. I think if I can say anything at all, is that we've had 259 million doses administered as of May 10th. So that is pretty incredible when you look at it. And we are monitoring very closely. The slide that you see here talks about the different monitoring systems. We have safety monitoring is incredible. We have the VAERS that everybody's pretty well familiar with. vSafe is something that is a texting form. We've talked about that many times in the past, where people can actually sign up for that, and then they get an automatic text asking how they're doing. And this has been an incredible feature for safety monitoring as we've gone through. And in fact, some of the adverse effects that we've picked up so far that are reported to the ACIP has come through this vSafe. And I highly encourage pharmacists to have their patients sign up for that while they're waiting in that 15-minute period. The vaccine safety data link and the clinical immunization safety assessment these are some sentinel centers that they actually have great data that they just monitor continually to see what it has. So we are monitoring very close. I will say that the other thing is that I don't like calling this side effects. To me, it's effects, or it's expected effects. These, the majority of things we see is because of an increase in reactogenicity. And the reactogenicity is what we would expect. If you've got a vaccine that's 95% effective, or 90 to 95, you'd expect to have more reactions to it because you're really stimulating the immune system. So I think if we could get pharmacists and physicians and all to quit using the word side effects and say, these are the effects that I expect from you. I will tell you that in many cases, the second injection on these vaccines is worse than the first. Again, an expected type of reaction that would occur. I've also seen some people discouraging patients from getting their second shot because of the effects they've had on their first one. And please don't do that. They need their second shot to be protected. Unless they've had a severe reaction to it, this is something that should not be postponed. When you ask specifically about some of the data that goes along with it, there's been a couple studies that have been done and published. JAMA had a publishing study just not recently, but it was a study that was done early on. It was completed in February, but they basically said that roughly 70% of the patients, this is with the mRNA vaccines, that 70% of the patients actually had local adverse effects, and about 50% had systemic adverse effects, most commonly pain and fatigue and headaches. Headaches are very common. They were saying about 25% of the population were getting headaches from this, myalgia, etc. One recent study, though, that did come out that was quite interesting was showing that if you got the vaccines after having COVID, your symptoms were actually either 2 to 4 times worse, yet the expected effects or the reactogenicity, than if you got the vaccine if you had not had COVID. So the patients that are getting it are reacting a little bit more to the vaccine if they've already had COVID. Again, that's not unexpected when you have their antibody levels that they've built up since then.
Well, no, thank you. I appreciate the points that you're making. Thank you for reminding everybody about more of the vaccines, making sure everybody gets vaccinated so we don't have that deferred care. And then this reporting, that's really, really, really critical. I like the fact that you're not calling it side effects too, because expected effects is definitely a key term there. So, yesterday you participated in the meeting authorizing the vaccination for 12 to 15-year-olds, and I know so many people have been waiting for this. But, what can you tell us about the latest information related to that and the Pfizer vaccine and the 12 to 15-year-olds?
First, talk about the Pfizer vaccine. It was recommended by the ACIP. The FDA had already approved it a couple days ago, but it was recommended that we do use it in the ages 12 to 15. We'd already had it approved 16 and above. The same dose as adults, 2 doses 24 days apart. Taking the same amount of time to observe the patients, 15 minutes if they're not had problems in the past with vaccines, 30 minutes more, but paying attention to teenagers because they actually tend to have more syncope-related type of problems. Again, expect the potential, and here it says related reactions, and again, warning them because again, this is a group that's going to complain a lot about it if you don't hear it. Tell them about the things that Chris said, the Tylenol, the Motrin, and then monitor with VSafe. Again, the parents can sign up for VSafe and can answer for the kids too, so it's really good. There was a few other things that we talked about also at that meeting. One of them was the co-administration. It kind of came out of the blue. We didn't see any data that was presented to us on there, but the co-administration of the vaccines, of the COVID vaccine with other vaccines, they said, go ahead and do it. This was a CDC decision, not really an ACIP recommendation as it was said, but they said that they've been monitoring data for a long time, whatever that means too, because we didn't see any data, like I said. So, but no time intervals. They can be given on the same day as other routine instead of waiting that 14 days. And the main reason is because, like I said earlier, we've got to get people caught up on their vaccines because the other vaccines are really about 20 to 30% lower than they were the same time before the pandemic had hit us. And all of this is supposed to be written in the MMWR coming out on Friday. I'm going to have one more thing to add to this also, but the vial, one of the things is the Pfizer vaccine now is going to be repackaged into smaller packaging units. We don't really know how it's going to be distributed. It may be going to the health departments for pre-distribution afterwards, but it's going to be, as it is now, it's like 1,170 doses per package when they send it out. They're going to cut that down to about 450 packages, which would be like 45 vials. So we're going to see, well, just keep your ears open to see how that's going to come. But I don't know whether that's going to health departments, whether it's going to pharmacies. I know their big emphasis is going to doctors' offices, what they're pushing on. Also, the other thing that they presented at the meeting yesterday was more information on the Janssen thrombosis with thrombocytopenia reaction that we had brought up in the past. If you remember, on April 13th, the FDA and the CDC both paused this because of 6 events that they picked up with this thrombosis with thrombocytopenia. And if you really think about that, at that time they'd been given 6.8 million doses, and they identified 6 events out of this. So that's tell you how close they're monitoring. We met the next day with the ACIP, and the ACIP basically wanted more data before they had some information. So we met a week later, April 23rd, and at that point, they increased it to 15 cases, but again, we had 7.98 million doses given. And the ACIP basically said that while this is a potential problem for it, the benefits outweigh the risk. So on April 27th, they resumed it. They presented more data yesterday that said that there's been about 8.7 million doses given. And we're talking a lot of doses, and then increase the cases up to 28. So the main thing is that this is something to warn the patients that there may be a potential. It is very, very rare. The COVID is not rare, and so there's no reason to hold back giving the doses, but at least it's information they can have if they choose not to use the Janssen vaccine instead.
No, that's great. Wow, what a great update. I appreciate so many good tips here. The co-administration, I'm sure that's coming up a lot now with kids trying to catch up with other vaccines, so really, really key. And definitely thank you for the update on the J&J vaccine.
One more thing, I just remembered there was a question, and I saw it went flash by in the first questions. I think we probably ought to cover that. We have a lot of studies going on looking at adverse effects and looking at potential side effects from vaccines. Historically, any vaccine effect that we've seen comes out within the first couple months of it going on, 6 weeks to 2 months. I'll give you an example. Things like the vaccine-associated paralytic polio with the polio vaccine, yellow fever with neurological diseases, GBS with influenza. All these came out very rapidly. So they're not unexpected to see them soon. It's not something you're going to see 5 years down the road that something comes back on that. Plus, it's very hard, as you know, to decide whether the vaccine's the cause of it. But again, the other thing that we also know is that in many cases, the adverse effects that come up are the same adverse effects that would occur from the disease. So in other words, usually we see more, like the GBS with flu. We see a lot more GBS caused by flu itself than being caused by the vaccine. So I wanted to add that to it too.
Oh, that's great. No, thank you for that, because the more time we spend vaccinating people, we have a little bit more experience with it. So that's a great point you're making. I definitely wanted to ask this question. This is like, I think, the $1 million question. There have been reports that receiving the COVID-19 vaccine has resolved the long-term effects of COVID-19 in patients experiencing symptoms. What do we know about this? Do we have information? Are you seeing this actually play out? Can you share information related to that? And Steve or Chris, either.
Chris, you're muted again.
Yep. So the question being, by vaccinating, do you prevent these long-term effects? Is that the question?
Correct. Or do you see them resolve or improve with a vaccine?
Yeah, to my knowledge, and Steve may have better data than me on that, I've not seen that specific question answered. I mean, it makes sense that by vaccinating people, really it's truly about prevention. Whether these, if they happen to get it, we know, because fortunately or unfortunately, especially the mRNA vaccines are incredibly effective at preventing this disease. And so while there are some breakthrough infections, even with being vaccinated, they're very low. And so those numbers are going to have to be looked at long term to really validate that question. So I don't have a great answer for that, Steve. I don't know if you have anything different.
Well, I mean, the issue is that what they're writing is the fact that those patients that have had COVID, if you go ahead and get the vaccine, it'll take away the long-term responses. And I'll tell you where that's been published. It's been published on CNN, Twitter, and Facebook. So that should tell you right there where the official word for that is coming from. So no, you're correct. There's not been much to see on that.
Great. Okay, perfect. Well, good. Let me go ahead and start looking at the questions here. The moderated discussion, a minute for your thoughts. I definitely want to get to some of these great questions that are being posted by the audience. So please share any questions that you have or any thoughts here, but let's go ahead and start picking some of these out, because I thought some of them are really, really important here. Let's start with this one. Let's see, one of the questions relates to Regeneron, diminishing or eliminating any of these manifestations. Do you have any information related to Regeneron and decreasing long-term COVID impact or effects?
Yeah, so that's a great question. With a lot of these monoclonal antibodies that are, we saw a huge uptake in our facilities compared to some of the others. Initially, there was a lot of issues with administration because it's not like an oral tablet where you can just go and get it from the pharmacy and take it. So there's a lot of, I would say, practicality and logistics of giving these medications. So it took a while for those to kind of get off the ground. And so we're still trying to figure out if that happens. Now, one of the potential benefits that has been published in some studies with, not necessarily just that agent, but other of these monoclonal antibodies, is that they do decrease your risk for maybe an admission to the hospital or some of these severe type symptoms. And one of the things I said earlier in the talk was that severity of illness seems to predict long-term symptoms. So the natural question, which is a good one, is, well, in those patients that received one of these monoclonal antibodies, do they then have a decrease in those long-term symptoms? I'm sure the manufacturer, if they're smart, is looking at that data right now, because that would be definitely, if found to be true, even more of a reason, to potentially, with these longer term morbidity side effects coming out, more of a reason instead of just treating them to prevent mortality, maybe it would prevent some of these long effects. But I've not seen that data published yet, but I'm sure it's coming in the near future.
Perfect. Great. Thank you. And this is a question or a comment question by somebody in the audience. I've had a few patients complain about food intolerances following COVID-19 infection with GI distress and chronic diarrhea. Is this commonly encountered by others? Are these some of the things that you're seeing, Chris, from the literature of some of the effects that you're seeing as long-term or as a result of COVID?
Yeah, great question. So the gastrointestinal manifestations are definitely there. It was one of my boxes there on my slide, and there's some data going into looking at how long shedding is occurring even within the GI tract. And there have been some studies that show that it can shed, fecal shedding of the virus can happen for really up to a month after initial infection and persist for a lot longer, somewhere around 11 days after negative respiratory samples. So we do know with certain viruses that there can be a post-infectious dyspepsia or a post-infectious irritable bowel syndrome. And so because of COVID and the coronavirus and its manifestations on the GI tract, that would not surprise me in those patients that may be having some longer term irritability with their bowel, manifest in a number of different ways: constipation, diarrhea, abdominal cramping, gas, things like that. So I think one of the things as pharmacists we can do, and I meant to mention this earlier, is, one of the things I'm concerned about is that people are just going to stop testing. And so even being aware that you have had the disease may give you some clue to some of these symptoms as far as the timing goes, but you never know unless you're tested. So with that, counseling patients that, yes, there have been reports of longer term GI irritability, but as long as they're mild symptoms, they would definitely warrant monitoring. But if it's anything moderate or severe, they would probably need to be referred to have that evaluated by a healthcare professional.
Great. Well, thank you so much. Very, very good information there. So hopefully that helps as those questions keep coming in. This is not so much a question, but just a comment, and maybe you can comment on the comment. One of the concerns are the impacts of newborn babies on moms that got infected during COVID-19. Have you seen anything related to impact on a pregnancy, or even the impact of medication used to treat COVID and potential impact on a baby?
Well, the impact of the disease, I don't speak a lot on, because we know that it does affect in pregnancy. It's like flu. It affects a pregnant woman more than it would a non-pregnant woman. But we have been doing a lot of monitoring in pregnancy registries that they've talked about too. And just published in New England Journal was one of the results that have come out of these registries. And they had followed, after mRNA vaccines, 35,000 pregnancies that have occurred with it while they've been on it. 86% of them resulted in live births, 14% roughly pregnancy loss, but that is actually lower than the number of pregnancy loss in the baseline natural losses. There were no neonatal losses, in other words, none after they were born. So they've not seen safety signals from the vaccines at all. But we do know that the outcomes, and I haven't specifically seen the outcomes on pregnancy, but we do know that the mothers are much sicker.
Mm-hmm. Oh, great. Thank you. This question has come up, and you sort of already hit on this, Steve, a little bit. If somebody has already had COVID-19 and they have antibodies, should they still get the vaccine? That's part one. Does it increase side effects, which I think you did address a little bit, and how long should they wait before getting the vaccination?
Well, there's a little bit of guidance along with that. The answer, first of all, should they get it? Yes, because what we do not know is how long the antibody levels last after getting the disease itself. And we're thinking that the antibody levels from the vaccine may be actually higher persistence than the disease itself. We know that the 3-month number is kind of the safe number that they've given people, and the fact that antibody levels tend to last at least 3 months. And you have to remember, we're just studying this stuff, like Chris said earlier. It's like, this is stuff that's just coming out. We don't have a lot of answers to this, but they are looking at them. And so they said you're pretty well okay to wait at least 3 months afterwards, but you don't have to wait 3 months if that's what if you want to get it. But definitely you should get it. And by the way, along with that is, are we going to need boosters? We don't know that either. We're looking and following levels as doing that. They are doing booster studies now to see if they can answer any of these questions, but they're not available at this point.
Okay, great. Let's see. I am getting a question here. You talked a lot about reporting, reporting any safety events or anything like that. Is there a way for people to report if they don't have computers or smartphones, like anybody who still wants to report safety monitoring? Because I've seen a lot of it is either through a smartphone or a computer, but is there a way to report if you don't have access to either of those that you know of?
Well, let me start off by saying, as a senior citizen myself, I don't have any friends that don't have a smartphone. So it's probably a pretty rare case that you'd have something like that. And yes, the VAERS definitely has a telephone number that you can call into to report adverse effects. That would probably be the best thing. The purpose of the BSafe is to send you a text to remind you to say, how are you doing? It's kind of not only monitoring for effects of the vaccine, but it's more of an aggressive look at trying to find out and follow it. With the VAERS is reporting something that's happened. So, and that can be reported by anybody. So yes, they do have a phone number for that.
Great. And I think Dan just posted the number there for participants to jot down and have available in case somebody can't report. So thank you, Dan, for doing that. I definitely wanted to ask this question because it's come up in several different questions coming through. Is the co-administration of other vaccines for only 12 to 15-year-old patients, or is this for all patients?
Everybody. That's for everybody. That's a great question, because we brought it up at that point. But this was a separate section that they discussed at the meeting before we got it, after we had finished the 12 to 14. So it's for everyone.
Great. Oh, I've seen several.
I might add that there was some concern about the fact that the reactogenicity of these vaccines being higher. What would happen with the reactogenicity of, say, the adjuvanted vaccines, this kind of stuff? There were concerns with that, but realistically, we haven't seen any of those problems. It was not reported as a problem. And I would still, until we have a definite answer to that question, I would still give the vaccines. I think we really need to protect our patients until we know there's a problem. Don't avoid doing that just because there might be a problem, because we don't know that there is one.
Okay, great. Well, thank you. Hopefully that addresses several questions that came in as it relates to that question. There's another really good question here as it relates to some of the follow-up information you gave about J&J vaccine. The new cases that you mentioned, and I know they're very, very small relative to the volume of vaccines given, but the cases that have presented themselves, the new ones, are they still very gender specific? Are they still primarily in women, or did they report more differences there?
First of all, I'm impressed with who's ever asking these questions, because they are really following the information, and it's great. Actually, these new ones that just came in, about 50% of them were men. And up until this point, about the first 17 or so, they only had like 1 or 2 cases of men. It was primarily in women up to about age 49. Now, this last batch that came in, up to the 28 cases that they reported yesterday, there were 6 cases that 6 of the additional cases, six of them were actually in men. So I believe that was the number. But yes, it's so it was shown up more in men now.
Okay. Okay. Well, great.
They're going to keep watching it too.
Yeah, that's interesting. Definitely, people are paying attention. I agree with that. Another question here. This person gets numerous questions regarding. I'm sorry, they keep popping up and they push my question. Numerous questions regarding how long these vaccines will provide protection, and will boosters be needed in the future? And will you please provide guidance as to what the evidence is showing so far regarding future doses that will be needed?
Well, again, that's an I don't know question. Chris, I'm just going to let you jump in with I don't know if you want to do that every time.
Yeah.
The thing is that we don't know that. We don't know how long the antibodies last from someone who gets the disease. We don't know how long the antibodies last after they get the vaccine. We do know there's some waning. The levels are going down some. We don't know if it's we don't even know what the level of protection is when you take a look at what we need for it. So again, these are things that we also don't know if the disease is going to be around. You know, what if flu has disappeared. What if flu comes back and replaces it again? And by the way, I do want to add that one of the big issues and concerns they have is people not wanting flu vaccine next year because there was no flu this year. Don't let that happen. Really push and encourage flu because it will come back. I mean, that was the main comment that we heard in a lot of the meetings I've been in. It's like, it will come back. But again, we don't know if we suspect it'll probably be around a long time. It may become like a flu type of thing where we can prevent it yearly. Interesting enough, I heard some discussions, and this was not at the ACIP meeting, but just some potential vaccine, mRNA vaccines, that they can combine different respiratory viruses in them being looked at now. So we might have new ways of actually preventing them or doing it, but we just don't know. They're studying the boosters in case we need them. They'll be ready to do it if we have to.
Yeah, the only thing I would add to that is, with all these variants that are circulating, the mRNA vaccine, so far, the data is that they actually provide pretty good protection against these. And so this is another reason to get vaccinated. The technology is so amazing with these vaccines because they can tweak them and adjust them pretty seamlessly to be able to protect against even more of these variants if we do go the route of a booster. So it's just a fascinating science. If you want to investigate it and look at it, it's pretty amazing.
I'm really glad you brought that up because again, with the variants, one of the reasons to give the vaccine is to prevent mutations occurring, because if you don't have the disease, the mutations can occur. And so that's another reason to talk to our patients about, you need to get this now.
Oh, absolutely. Well, I'm a big flu vaccine proponent, always have been previous to this, but I'm also now going to be a proponent of mask because I think that hopefully helped with a flu decreases, and then washing our hands and all the other things that we've been able to do as part of this whole process. So great question here coming in around the next vaccine age. I know we've just approved 12 to 15. Any insights, any thoughts about when they're going to go lower than that? And I know a lot of parents with younger children, younger than 12, are excited to have that opportunity for their kids so that they can put them in camps and back to school next year. Any thoughts about timing on that?
The studies are going right now. They're down to age 2 is where they're looking at it, at doing it. We have no results. We have no information yet, but we do know the studies have started. They said maybe by the end of the year, they might have some ability to make some statements about that.
Great. And then there are just, let's see, one more here. I am a pharmacist who contacted COVID on 3/10, so March 10th. I am still unable to work due to neurological or brain fog issues. Are you seeing any treatment recommendations for things like this with these presentations? Chris, maybe you want to take that?
Yeah, well, first of all, for the person who put that, I'm very sorry you're dealing with that. I can't imagine just not being able to work because of that. I've not seen something specific that addresses, and I'm glad you at least brought that up, is the brain fog. It's kind of this conglomerate of symptoms that are just kind of non-specific, wax and wane, but you may be obviously having symptoms every day. I've not seen a specific treatment necessarily for that because they're still trying to get their wrapped around what the actual pathophysiology is. I talked about the ACE2 receptor, but as far as what's happening to really cause the other manifestations once that virus enters those cells. So I'm sorry I don't have a specific answer for that, but I really hope that pray you continue to improve and can get back to work soon.
Well, with that, I just wanted to take a moment to thank you both for everything that you've been doing during this COVID pandemic. You are incredible. Thank you for all the education, for participating today, and for your continued work in keeping us updated. So I appreciate your time. With that, we're going to wrap up this part of it, and we're going to jump right into the next section, which is a review of ongoing activities and what's coming up for APhA.
Thank you for everybody.
Thank you.
Thank you. Wow, that was great. Great information. Thank you. So we've continued to be busy here at APhA with our advocacy efforts. And so since last time we met, there was some really good wins on the pharmacy side. As we all know, pharmacy has been on a quest to become eligible providers for Medicare patients for years, and we haven't had success. And COVID has really demonstrated the tremendous value that we offer for patients and accessibility, particularly in rural and underserved communities. So there isn't really a better time than now to capitalize on our momentum in Congress. So APhA worked hard to get legislation introduced in the House and in the Senate, and it happened. And very excited. What this legislation would do, it will allow pharmacists in underserved areas to bill Medicare Part B for services that are within the pharmacist's scope of practice. And so that doesn't mean that it gives us new authorities in terms of scope. It's whatever is allowed within the scope of the state where you're practicing. And so that's actually an important point, but that we're using in terms of selling this on the Hill. But we need your help. The bills need more co-sponsors, and we need you to reach out to your congressional legislators to get them to sign on as a co-sponsor. APhA has made it really simple for you to do this. Go to the APhA Action Center. The website is here, or just go to our webpage and type in Action Center. And we have a pre-populated letter for you to send that you can personalize it. You can type in your zip code, and it then pre-populates your representative and your senators, and it then will send the letters for you, or you can personalize them as well. So be an advocate and help pharmacists become Medicare providers. Let's go to the next slide. Another big activity that happened just in the last few weeks is APhA joined the National Community Pharmacists Association as an equal partner in a federal lawsuit challenging a regulation that creates a loophole and gives PBMs unlimited license to impose retroactive DIR fees on pharmacies, which is contrary to the intent of the law. So PBMs impose these fees months, weeks after pharmacists dispense the prescriptions to Medicare Part D patients. And so the lawsuit is against the U.S. Department of Health and Human Services. And a ruling that sides with us, the plaintiffs, would eliminate these retroactive clawbacks by moving them to the point of sale. And this will allow Part D patients to benefit from the negotiated discounts and gives pharmacies much needed transparency in their reimbursement. It's early on in the litigation, and there's a long way to go here. Just this morning, APhA launched an APhA Pharmacy Advancement Legal Defense Fund, which provides an opportunity for you to support efforts on this litigation and other advocacy efforts. So if you're an APhA member, you should have received an email earlier today. And it's also will be in the bi-weekly APhA legislative and regulatory update email that you will get in your mailbox later today. So be on the lookout for that. And then in the next slide, we show you this every week for those of you who are regulars, because I can't stress enough how amazing our practice resource library is, our COVID-19 practice resource library. We are constantly updating this database of information, and our newest resource includes very specific information about how to be reimbursed for administration of COVID testing and immunization for uninsured patients. So if you have uninsured patients, this resource should be really, really helpful for you in order to get reimbursed. And back to you, Sandra. Thank you.
Great. Thank you, Elisa. These are great updates. I'm super excited about the provider status legislation. I already donated to the Legal Defense Fund. I want to put my money where my mouth is and make sure that I'm supporting all of your hard work and effort to get us across that finish line on a lot of these really critical topics. But let's go ahead and talk a little bit about some of additional resources that we have in the APhA Library for Education. So 2 new resources out there. There's a 15 on COVID-19 that really talks about the accelerated vaccine development process. And I know as pharmacists, we're getting a lot of questions about the safety of the vaccine with the speed of how it was developed. But this hopefully will give you some great information and talking points as patients have those concerns, as we want to reduce vaccine hesitancy and we want to improve confidence with that. We also have a great quiz that is know the facts about the COVID-19 vaccine. Test your knowledge. It's a few questions and it's a really great exercise to see how you're comparing with your peers. Next slide, please. We also want you to join us May 25th. We're going to have a national town hall on building vaccine confidence. And so this is going to be on May 25th from 7 to 8:30 p.m. Eastern time. And we're going to have you have the opportunity to share your experiences, successes, concerns, challenges. We definitely want to hear from you. Hopefully you can participate, and the registration link is going to be available. It's in the handout for you to register for that. So hopefully you can join us with that. And next slide, please. And also, please make sure you continue to engage in Engage. We have an opportunity to share different experiences there, share, support each other, access the latest information. So if you're not active in Engage, please do so, because people are really sharing great information. And so the next webinar that we're going to have is on Thursday, May 27th, same time, same place. The topic is going to be motivational interviewing to address vaccine hesitancy. This is also going to be a program that CE and the CDC is going to help to support this. We definitely want to make sure we're getting as many people vaccinated and addressing any questions or concerns that they have. And with that, we're going to review some of the poll responses, the questions, and then also share the CE code with you. So going back to this question, a number of long-term side effects of COVID-19 occur in many body systems due to the virus initially entering which receptor? And we'll go ahead and have you respond to this. And the answer is the ACE2. So that is the correct answer, and most of you had that correct. All right, next question, please. Thrombosis with thrombocytopenia was the cause of the temporary pause in the use of which of the following COVID-19 vaccines in the United States? And so we've got Pfizer, Moderna, Janssen, J&J, or the AstraZeneca. That's perfect, almost 100%. J&J is correct. And the last question that we have for the quick poll is, considering the dozens of vaccines developed over the last 100 years, vaccine-related side effects are almost always detected within what time period after vaccination? Here we go, within 6 weeks. So pretty quickly after the vaccine, we start seeing impact. So that is correct. And with that, we have about 9 seconds. So thank you so much for participating in this incredible session. We want to again thank the speakers who joined us this morning, thank the staff for all the hard work that they're doing, and please stay engaged with us. And we look forward to seeing you in the town hall and in the next discussion. Thank you so much. Have a great rest of the week.